Great name, too.
Buds with Suds, yeah.
Great name.
Yeah.
Explosion.
And welcome, everybody, to Buds with Suds. I'm Richard Zombeck. I'm here with my co-host, Steve Lesnikowski.
Hello.
We have a couple guests today, but before I get to them, I just want to let you all know you can find us on iTunes, Stitcher, Google Music, Spotify, YouTube, and on the web at budswithsuds.com. I'd like to thank everyone who's been listening, and also for your emails and comments on iTunes, Facebook, and Twitter. If you're listening to the podcast and you like what you hear, please go to your favorite podcast provider and make sure you rate us and leave a comment. So last year alone, over 70,000 Americans died of an opioid, heroin, or fentanyl overdose. This is more than all of the U.S. soldiers killed during the Vietnam War. That's roughly about 58,000 in total. Here in New England, we've been among the hardest hit regions in the opioid crisis. The rate of drug overdose deaths in the region, 6 states, remains at or above the national average, according to recent data from the Centers for Disease Control and Prevention. The federal government declared the opioid crisis a public health emergency on October 26th of 2017. Our guests today are Gary Langis, who is an opioid historian and a harm reduction specialist, and his cohort, like Robin's Batman or Batman's Robin, Chris Alba, who is also a harm reduction specialist. Good afternoon, gentlemen, and thanks for coming on the show.
Thank you, Rich. Thanks for having us.
So, Gary, I want to start with you. If you can just give us a brief history of what you do, how you got into this, and what's happening most recently, I guess.
All right. Well, it goes back quite a ways. You know, I've been interested in opioid use since I was a kid. I don't know why. I have no idea. I think it was the early 60s that I watched the movie Man with a Golden Arm, and it just fascinated me. I don't know why, but, I started to do some of my own research during the 60s, and I visited places in New York. I did a lot of work down in Harlem from 1968 to 1972, and I credit that with my introduction to heroin, and I didn't know where my life was going to go at that time, but now I know why that I was witnessing what I was witnessing back then. And, I went through my life just raising a family, working my butt off, 6-7 days a week sometimes. And, and all through that, there were periods where, I'd disappear and it'd be... So I'd be strung out on dope and stuff. So in the 80s, my wife at the time had contracted HIV from using injection drug equipment, like using a infected needle, or a needle that was not clean. It was, borrowed. And that, she lived for probably 7-8 years after that, and at the time, I was battling my own demons and still trying to work. I was injured at work, and back then, I had been away from opioid use for probably about 10, 11 years or so, and I was in the hospital, and they had started to treat the pain with the Dilaudid and Demerol and all of those things that woke up this thing inside of me that just I just couldn't turn off. And I knew how important it was to use my own syringes and all of that, all of the stuff that we're supposed to do to prevent HIV infection. So I did that, and I was using at Boston. It was Boston City Hospital at the time. They used to have down in the cellar. They used to have these rooms off to the side. They used to be tunnels, and so I was using down there one day, and I got caught by this. I don't know if he was medical staff, a maintenance guy. I have no idea what he is. All I knew, he had a badge on from Boston City Hospital, and he asked me what I was doing, and I started talking to him. He was a good dude, and he gave me some clean syringes, and we used to keep bumping into each other, and he'd started to give me syringes to take back to the people that I use with. And we talked about HIV infection. We talked about how to prevent it. And I started to supply, the drug users in my network of using friends. And, one thing led to another. And it just gave me I said, you know what, I've got to do different things in my life. And I couldn't go back to the profession where I was working.
Which was what?
Which was in the auto business. I was working in the auto business, and I had a shop. I employed 8 guys, and I just couldn't do that anymore. It was just a lot of hard work, and it was draining, and it was really it just took up my whole time. If my family went on vacation, I was never there because I had to stay home and work, because I was supporting my family, and I was supporting habits. I was supporting a lot of stuff, that... I wish I hadn't, but that's the way it is. That's just the way it happened. And so now
So that guy was really your introduction to
harm reduction.
Yeah.
That was my introduction to harm reduction. I didn't know what it was at the time. And then I had heard that there were other folks in Boston, like John Parker and Harry Leno and Dan Sundquist, that they were doing a syringe exchange program in Boston. And I started to do some, I started to change my life a little bit, and I stopped using drugs, and I got into recovery, and I saw a lot of my friends that were just coming into recovery, and they were already infected with HIV.
So when was that?
That was in the late 80s.
So right at the height of the HIV crisis.
Yeah. And so, I continued to work. I had a feel-good job working at a gas station, pumping gas and towing cars and really wrecking more cars than I saved. But in the same time, I had a person in my life, I call him, he was my sponsor, and he taught me how to do what I had to do for myself, but also do what I had to do to not forget, the people that were still struggling with the life that I was, that I went through. And he introduced me to outreach. He taught me a whole lot of things. And that's how I got started working. First as a volunteer, and then as, being employed as an outreach worker. And one thing led to another. So, I went through the whole HIV stuff of caregiving. I took care of that sponsor. I took care of his brother. I used to go over to his brother's house and help with him, change his diaper and everything. It was hard to watch people that I loved disappear. My wife at the time, she passed away in 1993, along with my sponsor. He passed away in 93 also. And we...
Tough year.
It was hard. And I had to tell my children who at the time were oh God, they were probably I think 10 years old to 16 years old, that their mom had passed. And, I didn't want to, that stuff you don't, it's just not, it's not natural. My wife was too young. She was young. I think she was in her 30s or 40s at the time. So, I continued to work doing, the caregiving. I worked in an advocacy program for 5 years, linking people who were HIV positive or had substance use disabilities, getting hooked up to Social Security and representing them in front of an administrative law judge. And that was all foreign to me. Really, the only time I ever done it was in front of a judge was when I was sitting in the booth over there, and I really, I liked the work, and but after working there for 5 years, I got the opportunity to go back to the city of Lynn. That's where that's where I started out with my sponsor and his wife to do the outreach and to help keep the program that they started alive and up and running. And I worked there for 13 years. doing HIV prevention work. We weren't supposed to pass out syringes, so I couldn't do it through work. But I found if like a few of us got together, like some of those old folks, like from the Harry Linos and the Dan Sundquist from the AIDS Brigade and ACT UP, we got together and we formed an organization. We got our tax exempt numbers and so we did underground syringe exchange and civil disobediences. So we'd travel around the state and do demonstrations.
Where were you working at the time?
I was working at the time for Cab Health and Recovery Services.
Okay, and in harm reduction too, though, right?
And they had harm reduction too. They were trying to implement harm reduction also, but it was hard to get that implemented into treatment programs at the time. To get federal funding and state funding to do some of the stuff that really had to be done. So with this organization, New England Prevention Alliance, that we formed, we were able to do that. We were able to do syringe distribution and exchange. And that organization started we started meeting in 96 and we got it off the ground in 97. By 99, we were doing naloxone distribution, syringe exchange, and the civil disobediences where, we'd go and demonstrate like in cities like Worcester and New Bedford and Springfield and Lynn and places that were impacted by HIV infection. And that's what we were doing at the time.
When you say demonstrated, were those like public demonstrations or were they kind of just like off in parks or, I don't know, I was going to say back alleys, but
no,
there was not exactly what I meant.
Like all of this stuff is hidden in back alleys, right? So we wanted to make it a little more visual, and we would have, I did Worcester with my friend Eliza Wheeler, who's in San Francisco now doing work. And we went out to Worcester and we set up on Main South. We had doctors from not Brigham. It was Beth Israel, Dr. Camellia Graham, and all her students. They were out there in their white coats. We set up a table with syringes on it, and we started passing out syringes. And of course, law enforcement showed up. But at that time, they were told just stay hands off. Because the guys that I mentioned that we started with, we've all been arrested for this. We've all been arrested for exchanging syringes. We spent some nights in jail. We've all gone on trial, and Harry, unfortunately, was found. He was found guilty. Myself, I was found not guilty by a jury.
Guilty of what?
Distribution of syringes and paraphernalia.
So paraphernalia
laws. Yeah, and it was like at that time that was like in the late 90s, early 2000s, and we were like pretty much harassed on a daily basis. Any place we went, it wasn't it wasn't uncommon for 3 detective cars and a couple of police cars to pull up and surround us, or come into one of our meetings. We'd be having down the soup kitchen and surround the table and ask us to step outside because they didn't want to make a scene. And we usually point out the scene. You've already made the scene. I mean, you got a SWAT team in the soup kitchen, surrounding us. So I think that's a scene.
Let me back up just a little bit, because when you said a lot of it was hands off, can that be kind of similar to what's going on with the federal laws for marijuana now, and then localities are just kind of doing their own thing, and some are even ignoring the fact that people are smoking pot? And so when I hear you say that there was a hands-off policy, is that kind of like what you're talking about, or
Yeah, as far as the syringes go.
So the local DAs and stuff were saying just leave it, let it go.
Right, some of the local DAs.
Right.
Some of them. We had some real resistance from the city where I used to work in Lynn. We had a lot of resistance. But out of some of the cases that came out of Lynn, laws changed. I think it was in 2001. Massachusetts Syringe Exchange wasn't recognized as a statewide program. It was a statewide program. It was run by the Massachusetts Department of Public Health. There were 4 sites. There was Boston, Cambridge, Northampton, and the Cape down in P-Town. But some of the DAs, they were like a little more hardcore. Like I think out in Worcester that day, they just didn't want to like open up another can of worms. So they just let us do our business. You know, I mean, they did try to come up and get some syringes, but when I see a homeless guy with new construction boots on, I usually, that's a sign that they're probably detectives. So some reason I didn't give him syringes. I just told him he didn't fit our criteria.
And so, I mean, from then, has anything much changed since then?
Sure, with the syringe exchange. Like after my case, there was another case brought up against Maria Landry and Lynn that changed that whole thing that didn't bar zip codes from possession of a syringe. So if a user had a card from Boston, they were registered in the needle exchange in Boston, and they got caught in Newton, they couldn't be charged. Of course, it goes on for a while where they try to arrest people and charge them with possession of a syringe, which carried at the time 1 year in the House of Correction, and if so it was 1 year for every syringe you had. When I was arrested, I was facing at first 100 years.
It's crazy.
And I would have done it. They were going to feed me and give me a place to stay.
Three hots and a cot.
And I could have written grants from jail and opened some programs. But you know what? That's not what happened. I got found not guilty. Maria won her case. That opened syringe exchange up, and from there we work, because all of this you can really chew gum and walk at the same time. So I work for a large treatment agency. I also did harm reduction. I also advocated at the state level around syringe access, and I think it was in 2005, 2006 where finally we got syringe access throughout the state where pharmacies could sell syringes. So we got that, And then the next thing was the Narcan. How are we going to get a Narcan program up and running? We had been doing it for 7 years, and when I got pulled back a little at one of the organizations I had was doing work at. We'd go in and we'd do work with their participants who would people who use drugs, people who inject drugs, and we would do an overdose prevention training. We provide them with naloxone, but it had been putting that organization in jeopardy of losing their funding, And from getting caught then, I think that was a really good thing, because we hooked up with a board of director from the Boston Health Commission, and we began to have hearings on naloxone and how to open up a pilot program. And that year, it was 2006, they opened up the first pilot program in Boston, Massachusetts, the first legal one, in East Boston on a van on a Monday night, a Tuesday night. And, it didn't go over that big. I think the first night we got 4 people enrolled in Narcan, and it was a woman, she's retired now, Andy Epstein, who was the board member for Cambridge Cares About AIDS at the time, and she worked for the Health Commission. She helped push this stuff, and she was a little disappointed we only had 4 people, and I looked at her, I said, don't even worry about it. I said, you know what, they'll come. They definitely will come, and as the program's been up and running for 13 years, I believe, right? 13? It started in
2007 is when I started doing it.
All right, 2007, they started doing it in the States. So, 10, 11, 12 years,
That's the Narcan?
The Narcan program, OE&D, yeah, and... Legally, yeah.
What was going on before that?
Just the underground that we did.
And you had Narcan then, too?
Oh, yeah.
Where was that coming from?
Oh, we had a Boston Buyers Club where we ordered it from Chicago.
Really?
I can talk about that because the guy that I used to order from, he was like, I called him the Johnny Appleseed of Narcan. He would help everyone around the country get started. He's helped people all around the world get started with Narcan. He's responsible for saving tens and tens of thousands of lives. And, it all goes right back to him. And I had met him in Miami, and, he told me what he was doing, and it just sounded like a great idea. And he gave me Narcan, and then we started to purchase it from Chicago and have it shipped to Boston and delivered up in, we had to deliver it up in Ipswich by like sometimes we'd have big, truckloads, like a truck would be pulled down the street to this my friend's house to unload, and the police would be directing traffic, and on the truck was like hundreds of thousands of syringes and boxes upon boxes of naloxone. So it was pretty funny at the time.
Still the glass vials, I'm assuming, right?
It was a 10 milligram bottle that you had to draw out and inject with a like a 19 to 21 gauge syringe.
Wow.
So, but that's what we had. That's all we had. It worked. We did keep our data. We collected all the data from our reversals. The people that we were enrolled into our program. We did a lot of work in Lawrence and Lowell and Lynn, and Revere and Saugus and Cambridge. But we didn't have the capacity to like really roll it to get it going to the next step. So when the Boston Health Commission stepped in, that was like, it was sort of, we had to do we had to let go of our egos and let the city take over. Then we had to let go a little bit more and let the state take over. And, and I'm grateful for that because I didn't have the ability, and neither did anyone that I was working with. We didn't have the ability to do a statewide program. I mean, I'm not talking about a Fortune 500 nonprofit organization. I'm talking about like we scraped $250 together to do our paperwork, like in an office the size of a closet. I mean, it was like, it wasn't easy.
That was what year?
That was in '97.
Okay, so that was still 20 so years ago.
Yeah. So, I mean, that's how I've gotten involved, and I've stayed involved. I'm getting a little older now, so it's really hard to run up those 3 flights of stairs in Lawrence to do low threshold health care to somebody having, that has an abscess or like, overdosing or that needs syringes. But that's where, like, folks like Chris and the young bucks come in and do what they have to do. And I'm just amazed at the people that do the work. It's not easy work. We watch people die on a regular basis. And these are folks that, harm reduction isn't about giving somebody a syringe or a bottle of Narcan. It could be like a peanut butter and jelly sandwich to somebody that's hungry. It could be a blanket to keep them warm. It could be a little bit more love than they've gotten the day before.
I think that's the key. I think is the last one.
It really is. It's that connection. Because, like, the way I look at it, when you're using drugs, and so I did my research. So I know what happened to me. I know I got disconnected from my family. I got disconnected from my friends. I got disconnected from my community. And then it was like starting to get disconnected for society, going down that road of homelessness, drug addiction, and just not, just not wanting to live anymore. And, when that gentleman came up to me in the cellar of the Boston City Hospital, it was a lot more than giving me like a clean syringe. It was like he was telling me, I care about you, bro. I just, I just want you to see, I just want you to stay, alive, and I want you to be, not get a disease, and that's why I do this. So it's like connecting. It's like, and folks in harm reduction, there's a lot of people that talk down on it, and that's fine. If that's what they want to do, that's fine. If it makes them feel better, that's fine. But I really feel that like reconnecting and to the, the needs of that person at that particular time to keep them alive, to keep them disease-free, that's where I have to do. And whatever happens after that, it's not that I have a goal to get everybody like on the 12-step yellow brick road and, all rainbows and unicorns and butterflies. It's not like that. It's like, but more times than not, it does equal getting somebody in treatment, because nobody wants to be strung out and walking down around the combat zone in Boston with wet feet at 3 o'clock in the morning, hanging around pizza places and struggling, sleeping in doorways. So it's reconnecting, like I think a lot of these folks.
So while we're on harm reduction, I want to ask you a question, and I think Steve has one about that as well, right? If I'm not mistaken. My question's more related to what you were kind of getting at with the societal issues. And in one of the reports from the commission that you sit on, the Harm Reduction Commission, that's Charlie Baker's commission, or is it just the Massachusetts Commission?
It's Charlie Baker's commission that he formed. And
one of the statistics, I think, from Dr. Gaeta, Jesse Gaeta's report, was that this is before the opening of the safe injection sites. But that what the report said is that 91% of injection drug users reported a willingness to use a harm reduction program. 91%. So my question to you, since you're in this all the time, is what's the pushback? What's the problem? If there are 91%, if these are legitimate, and I'm not saying they aren't, but if these are real statistics, that 91% of drug users want to pursue some kind of harm reduction or even recovery, why the pushback on the part of, we can start with society, we can start with the legislature, wherever you want to start. But my question is what's the problem?
All right. I'm looking at Chris's shirt over there at PWUD, people who use drugs, right? And we're talking about 91% of the people who use drugs, all right? We're not talking about people in recovery. We're not talking about, doctors and lawyers. We're talking about people who use drugs. Of course, they don't want to die, and they don't want to become infected. But I think the kickback, it all comes from the stigma that we've created in our society over the last 140 years. The first law against opioids that, I could find was in the 1870s in San Francisco, targeting Chinese opium smokers. And so that was a law that, it just made it illegal to smoke opium, and it was really targeting like a population. It was targeting a race. It was like, a lot of our drug laws have been passed by, people's ethnicity and race. If you go a little bit forward, and you get to like 1914, the Harrison Act, that targeted really black men. It really
right.
did.
Well, and what's interesting too is that during the Clinton administration, there was the whole crack epidemic that was all blamed on African Americans.
Right.
And then you hear it a lot too now, is that the opioid crisis was never a crisis until it started hitting middle-aged white kids, or not middle-income white kids, right? When it moved to white neighborhoods, then all of a sudden we started paying attention. But you say race, so really kind of a moral failing, and that this is really considered a moral issue, and that you're not you're subhuman, and this is what you do, and so the hell with you.
Right. And from our earliest day, I'll talk from my earliest days, being educated around drug prevention. In school, it was like all scare tactics. I think they showed us reefer madness, and like how you smoke weed, and all of a sudden you're raping and murdering and
jumping out of windows.
I'm only slightly younger than you, and I remember seeing that in school. So,
like it's a good film, and but it's really, we've always portrayed like the drug dealer. All right, like they're out with their cloak on outside the schoolyard with a hat over their eyes. Feeble hands sticking out, with giving a free bag of dope for your first shot. And,
right.
And in reality, you look at it now, and it's like it's the cloak has been replaced by the captain of the football team jacket. You know what I mean? Yeah. It's like, of course, there's been a lot of introduction through the pill outbreak we had with OxyContin during the late 90s. And that did change the population a little bit, but like the crisis has always been there. And it's not that all of a sudden we have a crisis because there's a lot of white kids like shooting dope. It's I think we're more aware of it now because it was like nice and safe in little communities around Roxbury, stuck in like these little pockets of the community. It was stuck like in Detroit and South Chicago and Harlem in New York. It was always like, the inner cities, and they had a problem, and we don't.
The poor people, the colored people.
The poor people and brown and black people.
Right.
So it's not a crisis, I don't think, because of just white people. Because like right now, like really, I think there's an uptick in people of color overdosing and dying. If you look at the numbers now, but
Right. I want to just clarify that wasn't my opinion. It's that it's an opinion that I've heard a lot around here. That now all of a sudden, because it's white kids, now we're paying attention.
right.
Steve, you had a question.
Yeah, so sitting on this commission, it seems to me that the main talking point has been safe consumption sites opening in Massachusetts. What are some of the negative reactions that you have heard, maybe in those meetings and in public? And I know for me, somebody that works in recovery as a recovery coach that offers multiple pathways to people, the pushback seems to be that it's a very narrow viewpoint, right? It's going to be that, if we have these places where people can go to use drugs, it's going to normalize drug behavior. And my stance has always been, what normalizes drug use for the general public is having it unchecked, having people sitting out on the street shooting up, passed out. So what are you hearing a lot from this discussion?
Well, that argument of like normalization and just giving drug users the right and okaying their behavior and giving them permission to use drugs. You know what? I've worked in this work for about 30 years, and not one drug user has ever come up and asked me for permission to use.
Right.
We've heard these arguments with syringe exchange and syringe access. We heard it with naloxone. We shouldn't be giving them a drug to prolong their use, and that's the way some people look at it. Prolongs their use. See, I look at it. We all have our right to our own opinion. I look at it as like giving them another day on this earth. That they might make a different decision tomorrow. I don't know, but that's not my job to know what kind of decision they're going to make. To hang the carrot of putting like treatment in this stuff as a goal. That often is an outcome, but it's not the goal. Like, again, we go back to the initial needs of that person who might just need a sandwich that day.
Right.
So I know we're always going to get these arguments, and we get the arguments like from merchants. Those are a big pushback right now, like we don't want this in our neighborhood. And I look at it as a geeky old white grandfather. All right. So I have 7 grandchildren. All right. I really don't want my kids growing up in a society where they're walking down the street and they have to witness somebody shooting dope in a parked car or down an alley. I don't want to have my relatives come in from Cracker City, Indiana, and visit the Boston Commons and witness somebody having a fatal overdose in the Boston Commons. The store, the merchants, I don't know why. This would benefit their business because, it really doesn't benefit a restaurant, a coffee shop. If somebody goes in, uses a bathroom, and then all of a sudden an ambulance shows up and they're pulling some blue person out of the bathroom, it doesn't help business at all. We have a place that if you catch somebody using your bathroom and there's a supervised consumption site nearby, you can direct them down there, and they can get some of those immediate needs met. Your bathroom is freed up. There's no dirty syringes being left behind because, once you use a syringe down at an injection site, you dump it in a shop's container where it belongs. Right. And so it's a lot. There's a lot of benefits to our community. I don't want to have my grandchildren witnessing a lot of this stuff. I don't want to see, I walk down the street where there's a lot of heavy drug use in Boston, and just this past summer, I was talking to somebody. There's a woman sitting on the ground right behind us, and she's injecting drugs, right there on the sidewalk, broad daylight. The only thing I could do was stand in front of her, so everybody wouldn't gawk at her. Right. I would have liked to say, you know what? You can go 2 doors down and go in there, and they'll take care of you. They'll give you a place where you can inject. You don't have to rush, and And they can, if something happens, you overdose, they'll be there to address it. They'll give you a clean syringe.
So before we get kind of too far into the weeds on this, on the safe injection sites, I want to play a clip from NPR. I mentioned Jessie Gata earlier before, and this is an interview with her, just so that the people who are listening know what we're talking about here.
For many people, it's hard to accept the idea of public clinics with individual booths where drug users are monitored while they inject or snort an illegal substance and are revived if needed. But Dr. Jessie Gata with Boston Healthcare for the Homeless says all of the 109 studies she's seen on these sites show they work.
There's more than enough evidence now that we should be adopting this model.
Gata summarized the evidence yesterday for the state's Harm Reduction Commission, a group looking at ways to slow overdoses and deaths during the opioid drug epidemic. Gata says drug users at a supervised clinic in Vancouver were 35% less likely to die and 33% more likely to enroll in treatment than other drug users in that city. Gata presented another study that shows the same clinic saved more than $4 for every dollar spent because it prevented HIV, hepatitis C, hospital visits, and deaths.
There's no question we should be implementing supervised consumption.
So that's at least one person's opinion on the commission that I heard.
I love Jessie.
I can imagine, but from everything that I'd heard and seen, up until the point that people were going to Vancouver, everything seemed pretty positive. It was once people came back that there was a kind of a whole different story. Am I getting that right? Or
from our commission?
Yeah.
There were a few differences that were expressed, and there were differences. Like say, two people go up and they come back with two different views. And one view was that Massachusetts is not ready. We don't have the infrastructure. We don't have. We're just not ready. We don't incorporate harm reduction into like our healthcare, all that stuff. It's just not. It's not as prevalent as it is up in Canada. Okay, in Canada, sure, they've been doing great work and they have great programs, but there's no big gaps between Montreal and Boston, other than they have sites. We have 24 syringe exchange programs in the Commonwealth. I don't know how many OE&D programs, the overdose prevention programs, maybe 28 or something like that. Is it more?
I don't even know.
It might even be more. And so the infrastructure is there, and the harm reduction expertise is here in Boston. Matter of fact, we're pretty well right up on harm reduction. If we don't lead in some areas, we've been I've been doing this since late 80s. So we have a history of 30 or more years going back, and we've had some unbelievable harm reduction folks in this community that have they've left our community, like people that I've worked with over the years. They're one is the executive director of the the National Harm Reduction Coalition, based out of New York and Oakland. We have, in San Francisco, the woman that runs their Narcan program out there. She comes from Cambridge. That's where she got, all her experience down. She got a lot of experience in Massachusetts. We have other people that are in other parts of the country doing unbelievable work, and there's still a strong core of people in this state that we're ready. We've been ready. It's not that we're not ready. It's maybe the person that came back from visiting one of these sites isn't ready because.
Well, that's the thing, though, right? Because Marty Walsh was the one that made the comment about the infrastructure, right? If I'm not mistaken.
I think it was, yeah.
Yeah. Well, listen, I got a clip of him, and this is before he went to Vancouver.
The treatment numbers stand out for Boston Mayor Marty Walsh.
That alone potentially is worth exploring.
Exploring is a shift in Walsh's position. He now says these clinics are an approach Boston and the state should consider.
I went from a hard no on safe injection sites to am I in the right place on that?
Okay, so he questions himself there, but then when he comes back, this is a quote from the Globe. I just don't see how that helps, Walsh said. I actually think you hurt the addict because now they're going to be preyed upon more by the drug dealers because they know where they are all day long. And that was from an interview with the Boston Globe. So that's his take on it after coming back from Vancouver.
I kind of want to go back to what you were talking about earlier. The question you first asked was, what's the pushback when there's 91% of people, kind of like 91% of the stuff is saying that this is going to work. This is what we need to do. Is the behavior's been vilified. He talked about the drug history. If you go back to Nixon with the Black Panthers and the hippies, he vilified the crap out of the behavior. How are we going to help people engage in a behavior that's vilified right now? And so it's the stigma that's really kind of on the active user. Like we kind of look at an addict as this bad person, and how are we going to help this bad person by helping them engage in these bad behaviors? And
do you guys find that that's also difficult for them to even ask for help because they've been vilified and they may be vilifying themselves?
Absolutely. We're an intoxicated species. We've been using drugs or experimented with mind-altering substances since the existence of man. Since before even the human writing, there's drawings on cave walls of people eating plants to change, alter our mind.
An intoxicated species?
Yes. we're always going to...
I like that.
We're always going to be using something. You know what I mean? And it's not always bad. Drug use is not always that homeless, toothless person that we're fed that image of.
Right. Well, it's like my sponsor used to say, we come from Yale and jail.
Yeah.
Right. Park Place and Park Bench.
Park Place and Park Bench. That's it. And some people that use still are in Park Place, and they can get up and go to work,
right,
and kind of engage in life. That stigma kind of, if this is a bad behavior. So prior to the war on drugs, did we have this bad of a problem with drugs?
I don't know. I think so.
You think we did?
I think we did. It just wasn't criminalized like it was.
It wasn't criminalized, and people were treated humanely, and people rallied around their citizens and their community members and said, "Hey, listen, let's deal with this.
Right.
I care about you." Now it's kind of like that's bad. You know what I mean? They belong in jail. They're bad people, and so that not only does a person feel less than, and it makes it harder for them to kind of ask for any help because they become something that their whole life was taught that was a bad thing.
Yeah. And the other thing of the war on drugs is, once the criminalization came, and then you have the privatized prison system now, and you have the prison industrial complex and all the things that come from that.
Mm-hmm. We're an enforcement-heavy society. It's kind of like that's a bad behavior. We need to enforce you or force you to change that behavior, and by opening these sites, that's kind of counterintuitive to the way we've been taught as a society.
Yeah. I understand. I understand that. I understand, and I get that. What I'm having a hard time with, this in particular, with Marty Walsh, is that if we open safe injection sites, then the drug dealers are going to know where to find the junkies, right? I mean, that just seems completely ludicrous to me. And I guess the reason I'm a little incensed by this is because, we heard his attitude before he went up there. I need to change my mind on this. He goes up to Vancouver, right, where, let me see where that statistic is. First of all, the 91%, and that the overdose and drug use within a certain radius of safe injection sites dropped by 35% in a matter of weeks, right? And he comes back and he goes, oh, no, they're just going to harbor criminals and it's going to become a drug den. What the hell happened in Vancouver? What did he smoke while he was up there?
Well, we don't have any up or above ground injection facilities in the United States, and the drug business the drug dealers are doing fantastic business. If they have to be reduced to putting themselves to go down and stand in front of an injection site where they're going to be identified too, by law enforcement.
Well, yeah.
They're pretty bad businessmen.
Right. So what the hell kind of comment is this?
I think that's a ridiculous comment. I think it's totally ridiculous. It doesn't happen in needle exchanges. I'm not saying that maybe there's drugs might be exchanged here and there, But that happens at Starbucks and McDonald's and Dunkin' Donuts every single day. What are we going to do? Close down all these places?
Well, exactly.
You know?
It's not like there's a sign out there that says "Junkies are us," right? I mean,
right.
it's just kind of. I don't get the disconnect of his attitude before he goes to Vancouver, and then he comes back with this newfound, come to Jesus moment that, oh no, this is going to just harbor criminals.
Well, the commission just ended, so the report came out Friday. I don't think the conversation between the commissioners, I don't plan on stopping the conversations that we've begun with Marty Walsh or anybody else on the commission, for that matter. I'm not going to stop the conversation. I think it's important now to even talk to each other more. Talk to about the public relations. If we do open up this stuff, we have to identify, what positive outcomes are going to impact our community. Wait a minute, we're going to have we can reduce public injection so people aren't shooting on the sidewalk like that woman that I saw last summer. We're going to maybe get some of that drug use out of the bathrooms and put it into a place where people are treated with dignity and respect. And I just want to touch on one thing that Chris talked about, the drug war, and has it been was it like that we treated people who use drugs a little differently pre-drug war? Mm-hmm. But now since the drug war, so say it happened in the 70s, we start the drug war. There's hundreds of thousands of people in prison around the country. Now we have more than 2 million people incarcerated around the country, and most probably the majority of there some drug-related crime, right? So what have we really done? We've imprisoned more fathers and mothers and children. We've ruined some of the communities that have been you talk about the crack epidemic and the Clinton years and stuff like that. We ruined communities. We broke up families, and then, then there's one law after another, the forfeiture laws, that you don't even have to be convicted of having anything to do with a drug deal. But if you have a lot of money in your pocket, they can forfeit that money. I had a cousin, she was going out to buy a car, and she had cash with her, and they confiscated $17,000 from her in Texas. Wait a minute. For what? Oh, because it was a roach in my ashtray. A roach. That's a little, out of whack.
Oh, yeah. Yeah. No, I'm sure. And I'm sure a lot of these departments, that is how they support themselves off these forfeiture laws,
In private prisons, like you said.
Yeah.
There wouldn't be private prisons if it wasn't for the drug war.
100% agree.
Wouldn't be a private prison. How many, and I understand about the job security, losing DAs and all of this, DEA and all of this stuff. Yeah, sure. But there's transferable skills, we can teach other people more humane ways to treat other human beings than to do what we're doing now. And we're not only ruining that drug user's life, we're ruining their family, their friends, and the community. That's who we're ruining, and they can't, you can't get a job a lot of times. You can't get into forget about housing. If you go to get an apartment and you have a history of arrests, and I mean you're not going to be number one on the list,
right?
You're just not going to be.
So let me go back to the report. Because what the finding of the report were, I'm kind of a numbers guy, so I'm going to kind of just run off a whole bunch of stuff, okay? So there was reduced injections in public, reduced publicly discarded syringes, reduced injection-related litter. Okay, now this is with 90% of like we said, of drug users wanting to seek some kind of harm reduction, right? The statistics for these from 2016 to 2018 were 7,139 total visits. Of those, there were 47 naloxone administrations, 987 ED avoidances, right? 22% of those people were direct referrals to addiction treatment, which are paid and putting more money into the economy and into these organizations. And then again, 20% of those were direct connections to medical or BH care, right? So the same thing that we're doing as recovery coaches is we're trying to keep in a paid for model, right? And the way that we validate what we're doing is by saying, well, we're reintegrating people we're taking them out of the ER, we're putting them into primary care facility visits and primary care physicians, right? We're putting them into detoxes, whatever, right? We're not using the ER unnecessarily and putting them into some kind of therapy, right? All paid for by insurance, because Massachusetts, we're one of the fortunate states that 98% of our citizens have health insurance, right? So what the only person that I could find, and I want to play that clip, because the only person that I could find that had anything good to say about the visit was the mayor of Cambridge, Mark McGovern. So let me play that real quick.
If we can create a space where people who are already using dangerous drugs can do so and live so that they can access treatment at another point when they're ready, then we are doing something very important. We have to think boldly if we're really going to do something meaningful to save people's lives.
So, unbelievably pragmatic for a politician, as far as I'm concerned, right?
Yeah.
So, I mean, I'm asking you guys. I mean, what's going on?
Well, I'm not going to put up an argument against supervised consumption sites, all right? So my thing is, like, I believe this is, like, just part of the healthcare system that we have to implement for drug-using populations. And like the mayor said, Mayor McGovern, is that, like, you know, we're working with people who are unengaged. We're working with people who are using drugs. We're not working with people who are contemplating on going into treatment until they may hear about it, but they're not going to hear about it from their drug dealer, from most of their drug-using friends. But when they come into a setting like a supervised consumption site, it's the engagement. That's the most, you know, we're the staff are trying to connect with the person, and it just gives them an opportunity to sit down and take a break out of their chaotic drug use, because that's what we're talking about. People, you know, we're not talking about somebody that goes out and sniffs some coke like on a Friday night. We're talking about people that use 24/7, and a lot of them using very chaotically. That's all. Like, you know what? If we can engage that population, you know, this is a multi-pronged, multi-strategy approach. I mean, I believe in treatment. I believe in recovery. I believe in keeping people alive so they can make these decisions on their own, and give them the options. So a lot of people don't even know what a detox is, you know, and most of the people, like the target population, but this is something we really haven't talked about today. Like, you know, we've seen in Massachusetts outbreaks of HIV infection. Like,
Is it the tiger population?
Target.
Oh, Target. Thank you.
Target.
Really?
Target.
HIV outbreak again?
Yes,
Really?
there's a cluster in Lowell and Lawrence, 153 people, right? And Chris would know more than this. He works up there. And then they just, after one of our last meetings, they came out with, there's a cluster in Boston where they tested 6 people, and they're all HIV positive. A cluster of people. Huh. And that's because we've I don't want to say drop the ball, but we don't do as much education around prevention of HIV infections as we used to do. It used to be right there, like up front. And you don't see it like on the billboards anymore. You don't see it like, you know, in health classes as much anymore. So these people don't have that information, and we're dealing with a population that they don't have that historical look on what happened in 1980 and what happened in the 1990s, like I do, watching people disappear, like disappear right in front of you. I mean, going from 180 pounds down to like 96 pounds, like over the course of a couple of weeks. You know, it's not like that anymore. But we had a handle on it in the state. Like for a few years in a row, there were no new infections among injection drug users, people who injected drugs.
What do you attribute that to?
Harm reduction.
I attribute that no infections is like syringe access. If you look at the timeline when, you know, like we had needle exchange and then syringe access, it like 90%, like it dropped 90%.
And when that number leveled off, we lost a lot of funding.
So I'm not minimizing or doubting anything you're saying, but you actually do attribute the lack of HIV cases to harm reduction and to what you guys do.
Yeah. Honestly, yeah. HIV infection, hepatitis C.
That's awesome.
I think it boils down to like people being able to get new syringes. Now we have an uptick. What's the uptick from? All right. Now let's look at the drugs. The heroin market is being replaced by the fentanyl market, right? So with fentanyl, it's not as long lasting. So instead of doing 2 injections a day, you're probably doing 6 to 8, if not more, injections a day. And needles become like a little more scarce. So people are sharing a little more sharing more with their injection equipment than they used to in the past. And that's from lack of education that like we used to be able to provide. But like Chris just said, the funding on HIV prevention has been cut back because we reached such great numbers in Massachusetts. But now it's rearing its ugly head again. And I think, like this is a wake-up call. This is a wake-up call because not only would a supervised injection facility cut down on overdose, it also opens up an education and information on how to prevent HIV and other bloodborne injection diseases. So we have a population, and the population in Boston is like it's homeless young men, the targeted population right now, the ones that are coming up HIV positive. So those would be the folks that we would want to come in to a supervised consumption site.
When you say targeted by whom or by what?
Well, I say targeted by like they're at higher risk for HIV infection, overdose. So I'm talking about people who do the work out in the field. Like, Chris isn't going to go into like a Boy Scout or Girl Scout meeting to explain like, HIV prevention. He's going to be like down in Chelsea, like, in the drug using, where people are using drugs. And that's where he's doing his work. And those are the targeted populations we want to like really pull out of, like out and give them a little like light.
And like I said, that like it's not always just giving out this. Like we're providing education every time we sit down with them. It's not only the injection sites that spread of HIV. There's also the behaviors that go along with it, and a lot of sex work. And,
well, so let me ask you, Chris, because I've always been curious about this. So you work out of Healthy Streets in Lynn, right?
I do.
And so what is? Pick any day of the week and tell me what that looks like.
It could be sitting in court, fighting a stay away order for a homeless person, to sitting in a shooting gallery, making sure that the dirty needles are taken out of there, and I'm replacing them with clean ones and making sure that they have supplies. It can be knocking on a guy's door that's in college and working a 9-to-5 job who injects and still wants to make sure he has clean needles. And I do home visits for people that are dually employed in college and stuff like that too. So I run the whole gamut from. I do this work in Peabody. I do it in Beverly. I do it in Saugus. I do it in Revere.
Wait a minute. Those are all middle class kind of neighborhoods.
Oh yeah, I'm everywhere. Yeah, we do it everywhere. It's like you said.
You should see his office in Beverly. I was over there last Friday, where it is. It's great.
Yeah?
Yeah.
You need to mention Lowell and Lynn, like,
big couch and a chandelier over there?
No.
Elegant place. We get a lot of money.
So what, how do you, I mean, I worked out of Bridgewell where it was going into the ER. So I know how that relationship is made, right? Now where I work, it's referrals from the primary care facility. How do you gain that relationship? How do you gain that trust and make that relationship to have those visits and to make that a regular part of your week or your month? I mean, you mentioned you go over and you supply some of the guys or the college guy with clean needles and stuff. And how does that all happen?
So normally my first interaction with someone is like, hey, this is who I am. This is what I have. And their reply to me is, what the hell do I look like? Get away from me. And then, eventually, I'll get a couple people, and then the word gets out that, like, he's not a cop. He's got clean needles. He's got Narcan. He's got some good, education like he's been giving us. I give people homework, too. I give them a bag of supplies, and there's a pamphlet in there about endocarditis. There's a pamphlet in there about safe crack injection. So just from being out there, word of mouth, people say like, yeah, like Healthy Streets has been around for a while. So I hand someone a Healthy Streets card.
How long have they been around?
91.
91. Yeah, that's the first place I volunteered. Like when I
28 years.
So that carries its own, respect. Where like, he works at Healthy Streets. Everybody knows who that is. You know that like all we really want from them is to provide them with some.
So just like anything else, you form a relationship, you gain their trust, and then
that's it.
You help them stay alive.
And as long as we don't break that trust, we always stay credible, and we've been credible since '91.
That's really good. You guys are doing a great job.
So we always talk about like all the stuff we're doing and the progression of it. Like, so you can go like from what Gary was saying, where like they were getting arrested for doing it, their cars were impounded and compacted and stolen, and they'd go to get in their cars and the car would be just gone. And that, because like he's seen where I worked out of Beverly, but I really work out of our office is in Lynn.
Right.
My car is my office.
Right.
I kind of go to different spots and go around, but the progression of what we do and the mentality of it, like back when Gary was doing it, it was against the law. You can get charged with practicing medicine without a license and using, giving away syringes and get a year for each syringe. Fast forward it to now, what I'm coming into with it is I'm driving around in police cars giving out Narcan. Yeah. You know what I mean?
Yeah, that's great.
So it's kind of, it doesn't happen.
So some things have changed.
It doesn't happen overnight, and it's not going to happen overnight. The mentality of people with the safe injection facilities as well.
What do you guys think are the odds on that happening anywhere in the very near future, as far as the safe injection sites?
I think we're a lot further along than I thought we would be at this point in time. I couldn't tell you, I didn't think that we would be having these discussions a couple of years ago when we were just sitting down talking with some of the senators. And, then we had like 26 senators sign on to the first bill. So I didn't think, usually it's like 5 and then it gets thrown around. And so I think we're a lot further along than I thought we would be. I don't know, Gary would be able to talk more on that.
Yeah, like I can, it's like, I feel like I come from the Pony Express. Like I look at what these guys are doing out there today, and it just amazes me. It amazes me the relationships we've begun. Like, let's go with the police department. So, like, I've been harassed by police. I've been I've been set up to be fired by police. By them creating fake evidence. All kinds of nightmare stories. Like just being put in jail. Like, that's the way I grew up. And like today, Chris goes out once a week with the city where I do a little work in Revere, and they do a post-overdose visits to people who had overdosed the previous week. And we work with police and fire departments. Like that wasn't the case all the time. Like those were our adversaries, right? And I think getting probably about 10 or 15 years back when we first started to work with some of these community coalitions around Revere. I'll pick on Revere, all right? We work with the community coalitions, and the law enforcement we work with, they just didn't buy into harm reduction. It was junkies and junkies this and junkies don't care, da-da-da-da. You know what? It took a couple of years just for that to change. And then I can remember the chief that, was talking like that, doing like an update, and he was saying how they hadn't arrested anybody from the drug-using community in the last 58, visits to an overdose site. So that's a cultural change that's happening, that started to happen in the department. You know what? I work with probably about 5 or 6 officers. I think they're fantastic. They're fantastic, like guys, and women, and they get it. They teach us. I've been taught a lot of stuff about law enforcement since I've been here. I understand that they have a stressful job, and they're out every day. Like when they go to work, they don't know if they're going to survive that night, and I know the trauma.
You kind of look like a cop, Gary.
I know. Believe me, that's
you look like an old crusty detective.
I know, but I know what it is, right? Like they used to, people used to say, "Oh, that's a cop. That's 5-0," like back in the 80s, and 5-0, 5-0. But so you had to really build a relationship. But now I'm too old to be a cop because you can't be a cop after you're 65, right?
Are you that old?
So, yeah. So I'm 70. So I can't be a cop.
Are you really?
Yeah.
Wow.
So I can't be a cop.
You look great.
Wait till the autopsy.
Yeah, the outsides don't always reflect the inside. I know.
Right.
So
but it's that relationship, right, with the police, with the legislators, that we're seeing that's changed. Like, you know what they have now? Like, and a lot of them were in town training on the last week. Some harm reduction folks from around the country that came in to train on this mass spectrometer, so they can identify like the quantity of fentanyl in a particular drug. They can test this stuff. Like, you know, like if we were lucky, if we had an in at the police department, we might be able to get a drug tested, you know, through their system back years ago. But now with like Dr. Gator, she has a SPOT program where they hook people up and they monitor their vital signs and make sure they're still breathing. Like all we had was like somebody coming in, nodding out on the couch, and making sure that there was air coming out.
Putting a mirror in front of it.
Yeah, putting a mirror down their nose, or like, you know, just observing them all day. We've come such a long way, and you know, I applaud the folks that are doing this stuff now because it's a lot of work. You know, it's not just like, you know, some old crusty liquor, you know, like you described it. You know, just winging it out there in the street anymore. Like,
not going to get out of here alive.
It's backed up by science. It's backed up by, like, you know, evidence-based, you know, stuff that we've done.
Since when did that matter, though?
Well, it still doesn't matter to some folks.
I know.
This is evidence-based, and there's facts to back it all up. There's never been an fatal overdose in a supervised injection facility around the world, ever.
Right.
And there's some of them that have been in operation for more than 20 years. There's never been a fatal overdose. So right there tells you something.
Not to mention that the amount of money, like you said, about the emergency, like soft tissue damage, endocarditis,
exactly.
abscesses.
So we're coming up over an hour. I had one last question for you guys, and I think Steve has one as well. And then I also wanted to play one more clip of Dr. Gaeta because she's come up so often. So to both you guys, Gary and Chris, Mass General and now Lynn Union and Salem Hospital are starting and have started Suboxone in the ED. Right? Do you guys have any thoughts on that or anything that?
They're actually doing it out right out of the van. It's not. You don't even have to go to the ED. You can get inducted.
Well, Lynn Union and Salem are doing it in the ED.
It's in the ED,
right? So I mean, I'm almost afraid to ask, but any advice around that, or anything that that you guys have seen that could potentially cause a problem, or do you think that? I'm assuming you guys think it's a good idea.
I think it's a great idea. You know, the problem with getting people on medically assisted treatment in the past was being able to follow up and follow through with appointments and sit in a room for 2 hours and do intakes and then have to be sick inside a doctor's, like wait to be inducted on Suboxone, like sitting in a doctor's office for 2 hours going into withdrawals and then waiting for them to tell you that you're far enough into withdrawals to take this. Everybody out there knows at this point in time that if I'm not dope sick, I'm not going to take the Suboxone because I'm going to go in precipitated withdrawals. They know that. So now they're starting to come to the realization that, all right, I'm gonna do it in like the Bridge Clinic in Boston. We'll do.
Back up just a second and unpack that for me on the orals and the precipitate and that part that you just alluded to. So
explain precipitated withdrawal.
So if I take a Suboxone and I'm not, and I'm high on an opiate and I have a habit, it has a little bit of naloxone in it, enough to put me into withdrawals. So you have to wait till pretty much most of the opiates or the heroin or the fentanyl or the Perk 30s or the whatever it is you're actually using for an opiate leaves your system. And then there's a point where like you start to feel withdrawals and you can take a Suboxone and not go into withdrawals.
Okay.
It'll help with the withdrawals at this point.
And it's not pretty. It's you could be in that state of dope sickness, severe dope sickness, for like 10, 20, 30 hours. I mean, it could last for a long, long time if you take Suboxone early. Mm-hmm. And if you ever do, you'll never forget it.
Never. I wouldn't wish that on my worst enemy. It is hell.
And you've got a few. You've got a few, don't you?
I do. I do have a few. And that's that sickness. Oh my God, I would not wish that upon anyone because it didn't end. It didn't end. Like it was worse than cotton fever. Oh. It just wouldn't end.
But we always take like, you know, we think that like if I give this to an addict, they're gonna do that. Like if we have a conversation with them saying, hey, listen, do not take this until you are in a good part of your withdrawals. Otherwise, you will get real sick. And guess what? They can go home and induct themselves and not have to sit in a doctor's office and squirm in the chair for hours now. They actually could comprehend those directions and use them.
So do you find that people are willing to go home, go into withdrawals, and then take Suboxone?
Eventually, within the next couple of days, they will be sick at some point, and they have the choice to either eat a Suboxone or have to run out and
use again.
And go use again. So at some point, they are going to be at that point.
So that 91% is a pretty significant number when it comes to something like this, right? Because now it's not just a crapshoot, right? If we're saying that 91% of drug users want some kind of harm reduction or to go into recovery, right? Sending them home with a Suboxone, we're not. I mean, basically, because we're looking at doctors and the medical community that's saying we're just wasting our time.
This is this law right now that they're actually just starting to bring out. There's been a law in Massachusetts, not Massachusetts, a federal law stating that if I go into an emergency room and I say, listen, I have a problem with opiates, I want to get a referral out to methadone clinic. If there's somebody there available, they can make a call to the methadone clinic. If they can get an intake within 3 days, the emergency room is supposed to prescribe them enough methadone to get them to their appointment. That's all they're doing is implementing a 15-year-old law. That's a federal law that's been
ignored.
It's been ignored for quite a long time. So I mean, all they're doing is really saying, all right, maybe we should start listening to this because 15 years ago, this is what the doctor said we need to do. There are some people out there, like I think Boston does it. Like they'll do the intake right in the van, and then you'll have enough Suboxone to get you to your appointment, which will be within 2 or 3 days.
So on that, have you guys found that some kind of in addition to the medically assisted treatment, in addition to Suboxone and stuff, having someone like you or a recovery coach or something like that, do you find that increases the chances of someone maintaining some kind of recovery?
Mm-hmm. What is recovery to you?
That's right.
I don't think we have another hour.
I tell people that once I give them a clean needle and they decide that they don't want to share needles and they're wiping their spots, I say to them, welcome to recovery. You want something better in your life. You're starting to make small improvements in your life. You're starting to recover. That's recovery in small improvements over a period of time.
So I guess so. Let me rephrase that question. All right. Do you think, aside from going into an ER, overdosing, being handed a prescription of Suboxone, and saying good luck, do you think the human component of guys like you and guys like us makes that exponentially more plausible?
Absolutely.
Yeah. Yeah. And I say, like, again, we've been working for the last 5 years on these post-overdose door knocks. And so it doesn't stop with just that post-overdose door knock. We start to build a relationship with the folks. And I like to see it the way we've done it in Revere, where we have a harm reduction specialist right there, where he's working with a person that's using. All right, they're in pre-contemplative stages of the stages of change. All right, so now we're working with a harm reduction specialist. All right, and when that person starts to show signs that they want to go further, they want to get into and commit themselves to recovery, then it's like a warm handoff to a recovery coach, which is so helpful, so helpful, because that person's they might never been down that road before, so they've had us that we can take some of the rough edges off, and then we do the warm handoff. In some cases, like some communities are just using a recovery coach on the first initial thing, and I feel for the recovery coach because I've known of some that have started to use again. I've known of one in particular that had a fatal overdose. So it's like throwing them into the lion's den. A lot of recovery coaches, not all, they don't have the understanding of harm reduction as much as they do about treatment in their recovery. So they're trying to let's say they're trying to sell a product, all right, and the product is recovery. And if that person is in pre-contemplative stages, that person is more dangerous to the recovery coach than anybody, because you know what?
How so?
It could open up something in a recovery coach that they're not prepared. to witness somebody shooting dope, or even witnessing somebody like nodding, you know. So we try to make sure that person that's seeking recovery to whichever they want to define it, and give them that handoff to a recovery coach that will give them some of the skills of relapse prevention. Where are meetings? What a meeting is about? What treatment is about? What medically assisted treatment is about? You guys, you have all of that knowledge that you can give to somebody, but they're more receptive if they're ready for it. Like a lot of times they're not ready. We've worked with people for a couple of years before they came to that point. And it's really tiresome. It's dangerous, I think, it's dangerous for us. You know what? I mean, it's dangerous for us. I mean, I know I've gotten into trouble in doing this work throughout the past, but I've had a network around me. I've had supervision around me that have helped keep me on track and have helped pull me back in. So I think it's a real hairy job to do when you're working with somebody that's using drug. They're seasoned drug users, and a lot of times you hear it in meetings. They're going to talk you into using before you're going to talk them out of using.
I mean, I know it sounds like a ridiculous question to ask, that whole thing, but I mean, I find, particularly working in the clinical field, because we both work in hospitals and around a lot of clinicians, it's like there doesn't seem to be a lot of perceived value to that human connection, right? And we've known about that for decades.
Yeah. When I work with people, I get texts all the time saying, "Chris, thank God you guys are out there, because the only time I feel that 10 minutes you spend with me out there during the week is the only 10 minutes I feel normal. It's the only time that we'll have a conversation about anything other than who's got what, when's your check coming."
I have the same thing.
And then it's like, after we have a call, it's like, "Hey, how's your kids? You being safe?" And then it's right back into that chaotic spiral world. What Gary was talking about before too is we take the rough edges off. We try and get people treatment ready. We make sure that they're safe. They care about our first interaction with people is they really don't really care about themselves a lot of times. A lot of times I'll say, "Take some Narcan," and they're like, "I don't even care." And I'm like, "Well, take it, because I care. I don't want to see you die." And that leads to what else you got in your bag? And these are all things to help them to start to care about themselves. And it sparks that change. Those little things that they do to improve on their health show that they care more and more about themselves. And then eventually, sometimes, like you said, sometimes they'll follow that yellow brick road to recovery. And once they're treatment ready, it's always great to have a recovery coach to hand them off.
It's like what are we here for? Well, we're here for each other.
Yeah.
Right?
And I think a lot of that, we need to do more collaboration together with recovery coaches. I know I do a lot more now than I've ever done, right? But we all have, even with law enforcement, what I recognize is we all have something, we have more things in common than we do differences. I want a healthy community like the police want. I want to see a person recover like the recovery coach wants, and I think a lot of, our job is just what Chris said, treatment readiness. And that goes back a long way in harm reduction, because a lot of that used to come up. We got to get them ready for treatment. I mean, there was a guy who used to do needles in Boston, Adam Butler, and he had a group that he'd get together and they'd do surveys of drug users, and they'd rate detoxes by the food. Do they allow smoking? What do they use for their protocol?
Yeah,
and so people could they look at that chart and they could take a pick of what detoxes are. It was like a satisfaction survey of the detoxes.
Yeah. Well, listen, guys, we're coming up on, believe it or not, an hour and 20 minutes here. So that's a pretty long podcast.
It's worth it though. People are going to listen.
I think so too. Did you have a question, Steve? Or
so I was thinking, short of the healthcare industry in this country removing all profits from people's pain and misery and addiction. What can I don't know if this is going to be the right way to say it, but I'm going to say it. What can we do, right? So I learned a lot from you today. There's a lot of things I didn't know, and when I had that interaction with you last week, There was some stuff that I didn't know, right? So what can we do working this overall arch of addiction services? Like, what can we do to collaborate more, right? Because I feel like that is such a disconnect between whatever organizational ethos that we have, right? Like, the treatment centers are primarily abstinence-based and don't want to hear other sort of ways to recover, right? So what can we all do to sort of break that down, short of conversations like this? Because this isn't something that's able to be reproduced a lot, I feel. Not the podcast, but just these conversations.
I think it's doing, like you said, we need to do more of this. We need to I work with recovery coaches that work out of the system that we're involved in, right?
Yeah.
Maybe a little more meetings between these folks. I know a lot of did you receive your training through Massachusetts or Connecticut? Do you remember?
I did, yeah, BSAS, the Massachusetts
Right.
Recovery Coach Academy.
So maybe even requesting them to more conversations around harm reduction.
Yeah.
And maybe even face to face, invite some folks in, from one of the programs like Healthy Streets or something to really, to get a dialogue where we both understand each other, because we all, again, there's more things we have in common than differences. I want people to live a healthy life. I want families to be healthy, my community to be healthy. And I don't think, I would guess that that's probably about the way you feel.
Absolutely.
You know what I mean?
100%.
So there's no, this bickering sometimes you hear between the recovery community and harm reduction. You know what? It's just like we're working in that pre-contemplative stages. We're not going to meetings and recruiting people out of there to go to let them start using, clean syringes. That's not what we do.
No?
We don't need any more customers. I'm sure you don't need any more customers.
Right. Well, I think what ends up happening too is that, and it happens in every industry, is that all the little organizations that are doing this, whether or not they're well-meaning or not, have their own silos, right? They have their own silo of information. They have their own silo of networks, and there's not enough outreach. And I think while you alluded to the podcast, it's part of why Steve and I put this podcast together, is to bring more people in together, bring more of the community together, and to be able to talk about this and get that word out. Yeah. So, listen, I want to thank both of you guys. What I'd like to do is I'd like to end with one more clip from Jesse Gata, and then we'll call it a day. So, Gary Langis, Chris Alba, I want to thank you both for coming out here. It was a real pleasure.
Thank you, seriously.
Yeah, and we'd love to have you back if you've got the time or the inclination to do it. If this wasn't too torturous, we'd love to do this again.
Anytime, as long as I have a pulse. And thank you, Steve. Thank you, Rich. Thank you very much for having us here today.
Okay, and here's Jesse Gata again, Dr. Jesse Gata.
I know there are people who are dying because they are alone when they inject. I'm watching it happen. So far, I haven't lost someone in that situation, but we've come really close. That's the reason I feel desperate.